We are honoured to be joined by Matt, who's a kidney doctor from the University of Sheffield and is also involved in research. He's been a great supporter of the charity. He's been and helped us at a variety of events, and he's also been great in helping us to review medical literature. So great thanks to him. Could we possibly just go through the slides that we have now? So welcome to all, and if we could have the next slide. So these are who we are this evening, who are joining you for this session. And Matt will be giving a 20-minute talk shortly, followed by questions that you're able to ask. Next slide, please. We are really grateful to the National Lottery, who have supported us over the past 4 years with a grant. And this session forms part of the programme that they so supportively gave us some funds towards. Next slide, please. So as with all our events, this event is for information only. If you've got any issues or concerns, please consult your own specialist, GP or pharmacist. We don't promote or recommend any particular treatment. So please do make sure you consult with your medical professionals. Next slide. At any stage, you can ask questions as they come to mind. We will collate those and put those to Matt after he's finished his presentation. You can also ask those questions anonymously if you like on the chat feature. If you could all please make sure you do have your mics muted, just so that we can ensure that when we share this broadcast with others for their information, that it runs smoothly. Thank you very much. It now just remains for me to hand over to Matt, who'll be taking us through his presentation.
Just getting it ready.
Thank you, Matt.
There we go. Can you see that?
Yes, that's great.
Thank you for the introduction, Alison. So my name is Matt. So I'm a PhD fellow and a registrar, which is a kidney doctor at Sheffield. So I'll be talking to you about hypertension. So I'll go through what we're going to have a chat about. So I've developed the talk based on questions from people who have asked me in Sheffield.
Matt, can I interrupt, Matt?
Yeah.
I've just had a message to say that people can't hear.
Oh.
So, is that everybody that can't hear? Can you hear us talking? Can we get some hands up? Sound is great. Okay.
Yep, sounds great.
Graham Wood says that he can't hear. I don't know if that's Dr. Graham Wood. But everybody else is saying that they can. Okay. Many thanks. Matt, it sounds like people can hear okay. Thank you.
So it's like I said.
Sorry.
Yep. So like I was just saying, I've sort of developed the talk based on questions that people have asked me, questions from the charity. Professor Albert Ong at Sheffield's had a look as well. And also, thankfully, some of you put some questions to the PKD charity before this talk. So I've tried to address them as much as I possibly can as well. So it's all going to be questions, so top questions that people ask. So these are some of the questions that we'll be covering. We're going to go through these. So it's more just, if someone looks at this at a later date, they can sort of jump in the talk to find what they're interested in. So firstly, what is blood pressure? What is it? So blood pressure is the measurement of the force from blood against the walls of a blood vessel called an artery. So this usually comes as two numbers. So it comes as a top number and a bottom number. So when you've got the top number, it's called systolic, and that's when the heart is pumping. So it causes the blood to go through the body, through the arteries, and that causes pressure against the walls. And then you've got diastolic, which is the bottom number, and that's when everything's at rest. So when the heart's not pumping, that's sort of the normal pressure that's in the blood vessels. So that's why you'll get two numbers, and that's what they mean and where those numbers come from. And they both mean different things, but they're both equally important for how the body's working. So what causes it to be high? So there's loads of reasons why blood pressure might be high. I've put some of them in pictorial form here. So some of them will be things like diet, so an alcohol, smoking, that type of thing. Could be as we get older, your blood pressure tends to go up because the blood vessels aren't as flexible as they are when you're younger. High amounts of salt can affect the way that the body functions and put your blood pressure up. You can have different medical problems. So this is a picture of a thyroid. So thyroid disease can put your blood pressure up. If you're pregnant, your blood pressure goes up naturally. If you're stressed, genetics, certain medications. If you're going through the menopause, that can affect your blood pressure, and things like caffeine as well. So it's not just a sort of short-term thing with caffeine. It's also if you have a lot of caffeine for a long time, that can be sort of chronic changes to your blood pressure as well. So there's tons and tons of things that can cause it. Some of these you can adjust, some of these you can't really adjust. So things like the genetics and some of the lifestyle things, it's very difficult to make any sort of meaningful change to. But there are things that you can do to try and address these other things. So does ADPKD cause high blood pressure? So this is it's a tricky question to answer, but in the shortly, it's sort of yes and no. So the so as you get kidneys that have bigger cysts, these cysts can compress other parts of the kidney, and that can release some hormones that can put your blood pressure up. Just simply having pain from the kidneys and from the cysts, that can put your blood pressure up. And also some of the variants can affect the way that the blood vessels work, so they're not as flexible and they're not as responsive to the changes in the heart pumping. So that can also put the pressure up as well. So that it can make a difference, but it's not quite as clear cut. No one's done loads of research into this at the moment. And they are linked. So you often see an increase in your blood pressure, which is called hypertension, before you see a drop in your kidney function. And it's sort of around the age of 30 that people might have high blood pressure, whereas EGFR drops, they start more in your 40s and 50s, really. So it's something that can sort of precede a lot of the other changes you might see as your disease progresses. But why does it matter? So there's lots of reasons it matters. So some of these are related to the ADPKD directly. So there's some evidence that it can increase your rate of progression of your kidney disease. It can cause other conditions. So it can affect your heart, it can affect your brain, eyes, other sort of parts of the body, and they can have a knock-on effect on the kidneys as well. And there's some studies that show that having a high blood pressure might make your polycystic kidney disease itself worse and vice versa. So you end up in a vicious cycle, but that's not entirely clear at the moment. And how do you know if your blood pressure is too high? So some people don't actually know that their blood pressure is high. They might not have any signs that their blood pressure is high. You might check it from having your blood pressure measured, or you might from some of these warning signs that I'll mention. So firstly, for no signs, so about 4.5 out of 10 people don't know that their blood pressure is high because they don't have any symptoms, and if you're not getting the regular sort of blood pressure checks, you'll have no idea. And that's quite important because you can sort of go on in the background without you knowing about your blood pressure being high for quite a while. And in that time, it could be causing damage. Even a small amount of your blood pressure being raised can cause damage over a long time. So it's important to know about it. But the way that people generally find out about it is through having your blood pressure measured. So these can be in a few different ways. So it can be when you come to hospital, or just a clinic or an office blood pressure monitoring, they call it. Or it could be when you check it at home on your own monitors, or it can be due to when you get sent for a 24-hour blood pressure monitor, which is called ambulatory, which just means as you're sort of going about your normal day. So if where you have a cuff on, and then it just does little intervals of blood pressure measurement all throughout the day, and then the doctor at the end can then see how your blood pressure changed and how it is in different times of the days or with different activities. So that gives you a bit more of an accurate sort of reading of your blood pressure. So I mentioned that there's some signs or sort of problems that can happen when your blood pressure is high. So these are some of them. So these can be things like strokes, headaches. If you've got a high blood pressure, you can have visual changes that might be picked up by the optician. Same with the retinal changes. People might get sort of blurring of the vision, go to the optician, and then they have a look at the back of the eye and see signs of damage. People can have a higher risk of a heart attack or heart failure, kidney disease, which we sort of already mentioned, and sexual dysfunction as well, especially in men. Men can find it difficult to maintain an erection, and that might be a way that they find out they've got a high blood pressure in the first instance. So there's lots of different ways. Some of them are sort of regular checks. Some of them are from, if you've not had it checked or you've not known about it, then you might find out about it through a different way. So what is a normal blood pressure? So a normal blood pressure in sort of the back of my head is 120/80, and that's what we're taught at medical school, is that is a normal blood pressure. So usually we say to sort of for people to aim to be less than that. But there are some evidence for PKD that having slightly tighter blood pressure target is better. So if you're in this top age group, so if you're 18 to 49 and your kidney function's above 60, you have a tighter target. So we aim for a little bit of a lower blood pressure to try and stop the damage happening to the kidneys. If you're older, so you're over 50, or your kidney function's not quite as high as 60, then we sort of revert back to that sort of standard target of 120/80. And this guidance comes from, it's called KDIGO, which sort of looks at all the evidence and then you decide what recommendations there should be for people that are in Europe usually. And that's coming out soon. So this is sort of hot off the presses. What can you do to control your blood pressure? So some of them be lifestyle changes that you can make, and some of them are sort of medication changes. So some of the lifestyle changes, which aren't by any means easy, are things like reducing salt in your diet, reducing the amount of processed food, because that has a lot of hidden salt, making sort of better lifestyle choice in terms of what you eat, so avoiding things like lots of takeaways. Obviously, no one's going to say you can't have any of these things because life's not worth living, but it's sort of doing things in moderation. We also advise about exercise. So the recommendation is to do 150 minutes of exercise a week. It's a fairly high order that I'm not sure I meet it, but I think that is a good target to aim for. Obviously with PKD, we say not to do things like heavy contact sports, so sort of more cardio things would generally be better. And the same with things like weights. Sometimes we say not to do lots and lots of really heavy weights like deadlifting, again, because you can cause issues with the cysts. But what about medication? So this is a medication list for a patient that I saw in clinic. So they're on these different medications. And when you first look at them, it might seem quite arbitrary, but it's a very, very simple stepwise thing that we follow that sort of determines which medications get started. So usually these type of medications are the ones that are started first. I put examples on the right-hand side just so you can recognize some of these medications because some of you might be on them. So you can be on an ACE inhibitor, which is ramipril. You can be on an angiotensin receptor blocker, which is losartan, or one of these new ones, which I'm not sure many people will be on yet, but it also falls into this group. And there are some important things to sort of know about this specific type of medication. So usually the advice is for sick diarrheal. So if you're unwell or you're dehydrated, we usually say to skip these medications because they can make you more dehydrated and they can make your kidneys suffer a little bit, really. So we say stop them for a week or so whilst you're unwell, then you can restart them back afterwards. You shouldn't really ever be on more than one of these medications because they work on the same bit of the kidney. So you just end up with a lot more sort of risks and a lot more side effects than you would do otherwise. So you should only really be one of these. So very few patients that might be on two, but that's by far a rarity, really. And these medications are often first started because they've got lots of other benefits. So these particular medications are good for reducing the amount of protein in the urine. If you're leaking protein, they reduce your chance of having a stroke or having a heart attack or angina. So they're medications that often get started first for that reason. When you sort of, your kidney function maybe isn't quite so good and you're nearing dialysis, that these medications are usually stopped and you get a little bit of your kidney function back after that. And that's just because of the way that they work. They work by sort of narrowing the arteries to the kidneys. So that's how they tend to work. So if you release that a little bit, it tends to have a little bump in your kidney function afterwards. After this, you might be on one of these medications. Again, I put some examples on the right-hand side. So this would be one that would be added into that last one. So you'd be on the ramipril, for example, first. And if your blood pressure was still not quite as good as it could be, even on the top dose, they might add in this medication. So one of these is amlodipine. So a common side effect for that people might get is leg swelling. It's not related to fluid. It's just where the fluid is being held in your body. It's not sort of the same as like fluid retention. It's slightly different. It's leaking out of the places where it should be. Or you could be on indapamide, which is a thiazide-like diuretic. So that will make you go to the toilet a little bit more than you would do, say you're on amlodipine. Step after that, they'd add those two ones on the last page together because it'd be one or the other. Yep. And then finally, for the cholesterol, you'd add in an extra type of blood pressure tablet. So that could be something like bisoprolol, which works on the heart, so it can slow the heart rate down a little bit. Or it could be on doxazosin, which affects more of the blood vessels than the heart. And again, it kind of depends. Yep.
Hi, Matt. Sorry, I just wanted to explain. Some people seem to have lost being able to see the presentation, but some people haven't. So we're not sure exactly what to do, whether to try and reload that or not.
Should I stop it and start again and share it again and see if that does anything?
Would you mind just
No,
from where we're at, if that's okay?
Fine.
I'm sorry about that.
No, it's fine.
But we don't seem to be able to.
Oops, is that back?
Could everybody just, hopefully everybody can see that now who had a problem earlier. I don't think we can do much more than that. So we will we'll resume now and hopefully just pop it in the chat if you're now able to see. Thanks very much, Matt.
Want me to wait till people have said that they can see?
Yeah, bear with me. Let's just
right.
Let's just see what people are saying. Oh God. Yeah, I think everything. Yeah, I think everything's okay. Sorry about that. Thank you, Matt.
Me. So
thank you.
That's right. So whilst this medication list might seem a bit arbitrary, there are sort of reasons for these different medications being added in different steps. And some of them have these extra added benefits, which is why you end up on these ones instead of maybe another one. And that also influences, say, if your blood pressure was going the other way and your blood pressure was on the lower side, that might influence which one of these medications gets stopped first. So things like the ramipril, if it was just because your blood pressure had been a bit too treated, they might keep the ramipril on for as long as possible, really, and adjust some of the other ones. I mean, it's all about sort of what they're doing for the body, not just the blood pressure, but other things. So like the ramipril one in particular, and the sort of losartan and the new one, they all have these extra benefits, which the other ones don't have quite as much. So someone asked you if you're on these medications for the rest of your life. So it's a sort of yes and a no to that. It kind of depends what happens, really. So if there was another reason that your blood pressure was high, so if you made some lifestyle changes, you might not need as much of those medications, so those doses could be dropped down, or even the medication could be stopped altogether. As we get older, your blood pressure goes up slightly, but overall, if you sort of stand up too quickly, your blood pressure might drop, and that's what we call postural hypertension. That can be quite symptomatic for some people, and that as a result, we sort of are a bit more lenient with the targets and say, oh, we'll accept a blood pressure that's a little bit higher, because that means that when you stand up, your blood pressure doesn't fall to your boots. So again, that might be a reason why we might say, oh, change the dose of this a little bit. And the same for the ramipril one, which I said, if you're sort of nearing dialysis, they might say to stop that. Or if you had high potassium, again, that's another reason why they might stop that one. So how should you measure the blood pressure? So we'll go through these fairly quick. So I think it's a good idea to use a home blood pressure monitor. Usually we sort of advise to check it once a month if you can. It shouldn't be too arduous. So it's probably a few minutes, isn't it, to check it once a month. Smartwatches people do use, they're less accurate. So it's difficult to sort of rely on those readings, but it would be able to pick up a trend. So if you notice the trend had changed, then that is a sort of useful indicator. But usually we'd say you'd need to then check it with a proper cuff rather than anything else. These 5 R's are sort of suggested by somewhere in America, which I thought were quite good, and how to measure your blood pressure the right way. So they say to rest it for 5 minutes, to not talk or sort of move or do any actions at the time. Remove the upper arm clothing if it's something thick like a jumper. Thin t-shirts are generally fine. Rest your arm on a supported surface at the level of your heart, just because it's measuring the blood flow that comes from your heart. So if it's going down, you're sort of changing the pressure that's in there. And then finally, just making sure you rest at rest. So you're sat down, relaxed. Some other top tips as well. So it's good to make sure you've got the right size cuff, because that can influence the blood pressure readings. I generally advise people to take it at the same time of the day, because you get a variation, which I'll show you on the next slide. And I usually say take 2 or 3 readings when you do it and wait a minute between them, because sometimes if you've sort of rushed and gone to get the blood pressure cuff, the first reading might be quite high, and that might not be reflective of everything. And I think the best thing to do then is to sort of note down all the readings. Some people make an average, and that's useful. But even if you just wrote down all the readings that you took at the time, and when you go see the doctor, see the nurse, or pharmacist, you can just let them know about the blood pressure readings. So cuff sizes make a big difference. These are all the cuff sizes that I could find from one particular brand. Or you can see the little tiny one for infant babies going all the way up to sort of a large adult. And there's a big difference. So if you've got too big of a cuff, it's going to say a completely different reading to if it's too small of a cuff. You need to get one that sort of fits right based on your arm circumference. So if you measure where the cuff would go, you can work out which one of these you might be. And I mentioned about things changing over time of day. So this is a graph that I got from a study showing how your blood pressure varies within a day. So when you're asleep, your blood pressure tends to drop a little bit. But if you imagine, if you took your blood pressure at different times of the day, whenever you're taking it, you'll fall foul of these sort of variations that naturally occur in your blood pressure. So usually I'd say if you're going to take it at a set time. So if you're going to take it at 7 o'clock at night, take it at 7 o'clock at night each time. And then you can get a little bit more of getting rid of some of this variation that you naturally would get. I generally advise patients I see to write them down. So that can either be on paper, it could be in the notes app. And there's some good blood pressure measuring apps. This is one that I found called My Blood Pressure, which seemed quite user-friendly. And then you can just show us when you come to clinic. So that's incredibly useful for us because sometimes when people come to clinic, they've rushed in. Sheffield's got like next to no car parking. So people have had a mad rush for a car park, climbed up the hill to the hospital at the top, and then the blood pressure is obviously going to be high because they're all stressed and bothered. So it's good to have these home measurements because then we sort of know, well, actually, that's not reflective of how you are normally. I think it's good to know the target that we mentioned about before because if you notice you're not reaching that target, you can let the doctor, the nurse, the pharmacist know, and then they can adjust your medications. And then finally, on this little bit, so when to seek help. So if your blood pressure is above that target on a regular basis, that would be a sign to me to say, speak to your doctor, nurse, pharmacist when you next can. There's no massive rush to that unless it's very high. So if the top number's above 180 or the bottom number's above 120, and that just suddenly happens, that can be dangerous. So the advice generally there is to get in contact with either the GP or with the kidney doctors or the kidney unit. And if you have any warning signs or warning symptoms that we talked about before, so that was the things like visual changes or headaches that are not going away, that seem out of the norm for you, that could be another sign to seek urgent medical help. But otherwise, if your blood pressure is a little bit up, it's not a sort of blue light, oh my God, emergency, let's go speak to someone. If it's a little bit up, you can speak to them sort of near next available appointment or during sort of working hours, you could contact the unit. I'll finish off on some special situations which got some of the questions that I was asked to cover by yourselves. So I don't want to lose anything. So pregnancy can affect your blood pressure quite a lot. So it usually falls in the first half of your pregnancy and then it goes up higher than it would be normally for the rest of the pregnancy. We usually advise to do similar monitoring to what people that don't have PKD but do have chronic kidney disease. So every 2 to 4 weeks, people should be measuring their blood pressure. And most of the time we say to aim for less than 140/90. And the reason for that is it's a little bit higher because you need that extra bit of blood pressure to make sure enough blood gets to the baby and they can develop properly. We say to continue the medications unless your blood pressure drops below these points that I've written there. But there are some changes to the medication. So because medications that are sort of more recently developed probably will never be tested in pregnant women, you're sort of left with these medications that are sort of more old hat medications that have been around for a long time. So we know that they work and we know that they're safe. I'll put the name of some of them on there if you're particularly interested. Sometimes blood pressure can cause preeclampsia, but I won't go into that because I don't think we've got time. But that can be related as well in pregnancy. Menopause, someone asked about. So in menopause, you lose some of the hormone called estrogen, which is the female hormone. And that loss in estrogen can cause an increase in your blood pressure. So to treat that, people can be put onto HRT, and that can cause some differences in your blood pressure. So if it's a patch or if it's a gel, generally that can help reduce the blood pressure a little bit. But sometimes if you're on a tablet with a high dose of estrogen, that can make your blood pressure go high. So that's probably a good one to speak to the GP about. But it's good to know that having HRT can affect your blood pressure. Someone asked about exercise. So they said that they had a low blood pressure after exercising. Usually that's not concerning unless you were getting symptomatic. So if you were feeling lightheaded, dizzy, anything like that, then that's maybe more of a problem, and it's probably worth checking your blood pressure and speaking to your GP, speaking to the nephrologist, your kidney doctor. If it's a little bit low afterwards, I'd probably recheck it 10, 15 minutes later if you're not feeling too unwell. And then if it goes back to normal, I probably wouldn't pay any attention. Someone asked about holidays, and they were specifically asking about cabin pressure. So apparently when you're flying, you can get a slight increase in your blood pressure just because of the air, the situation and the sort of environment being pressurized. That shouldn't cause any long-term effects of anything. What can affect is if you can have a risk of dehydration during holidays. So if you're away somewhere hot and you're taking things like the Ramipril, if you don't feel that you're going to be able to keep on top of your drinking, then sometimes it might be best to sort of skip that medication for a little bit. Other conditions, so someone asked about steroids. So high steroid levels can cause high blood pressure. So if you're on steroids for another reason, so some people will be on them for transplant, that can increase your blood pressure. Having thyroid disease, that can also affect your blood pressure. It makes one or the other go high depending on whether it's high or low thyroid. Someone else asked about nephrectomy. So it's another one of these things where there's not tons of evidence about it and not tons of information about it. But if you've got a big kidney and you get a nephrectomy, you're going to have less compression and less sort of stress hormones being released by the body. But at the same time, because if both kidneys were removed, you'd lose that sort of normal feedback where the kidneys are involved in managing the blood pressure. And that would have a knock-on effect on things like your fluid levels and sort of salts that are in the body as well. And that can make blood pressure quite hard to manage at that point. So it depends really if it's a single nephrectomy or a double nephrectomy really that would influence what happens. Someone else asked about pediatrics. I'll be honest, I'm not a pediatric doctor or an adult doctor, but some little bits just to end this on. So we usually advise people that have children that their children should have their blood pressure checked annually at least. They would do the normal lifestyle changes that we sort of talked about before. It's tricky with the target blood pressure, and I've put that on just for reference, but I'm not expecting anyone to remember this. But the best thing to do is probably speak to the GP or speak to the kidney doctor or the pediatrician about what your individual child's blood pressure should be. They end up on very similar medications, but the doses will be different, and sort of the titration, so how much it goes up and down, would also be different. So it's really complex, and this is why it's really difficult to sort of say what the target blood pressure is. So what the doctor would do is look on a chart like this, which looks for a boy or a girl, and it looks to see where their height and their age and their weight fits. They then look on a sort of sheet that says, if your height and weight are in this sort of level, then this is the blood pressure that we'd aim for, and that's how they'd work it out. But it's not simple by any means, and I think it'd be best to speak to a doctor and nurse about it, and they should just give you a target blood pressure. So that's the talk in a nutshell. I've got a very fast accent from Yorkshire, but hopefully that would not been too whistle-stop tour. We've talked about all these different things, so hopefully by now you're able to sort of answer some of these questions, and hopefully it's prompted some questions. I could see there's some conversation, some chat questions as well, so I'd be happy to take them now if we're happy. Should I stop sharing so I can see?
Yeah, that's great. Thank you, Matt. That was really, really great. I've certainly learned a great deal in the past half an hour, and I'll be coming back to that talk again to refresh my knowledge. We've had a number of questions, and I'm really hopeful that now people will put some more questions into the chat, and I'll do some of those. And Jane, do you have any that you found already to ask Matt?
We had a bunch of questions pre today's webinar, and I was sort of following through them. It looks like Matt answered most of them. There is one in the chat. It's a slightly obscure one, but I think we'll start. We'll ask that anyway. How long after having a cup of coffee should you take your blood pressure? I told you it was obscure, but
yeah, I'd probably take it before, to be honest, because I suppose the caffeine, sort of how long caffeine lasts in the body, is probably about 4 to 6 hours, I think. So I think if you're taking it within that time, you might have an increase in your blood pressure than you would do otherwise. Again, it's that sort of trend. So if you always had a coffee and you always checked your blood pressure afterwards, and that's how you always did it, then it's probably not such an issue, because you can sort of take into account that little variation. But personally, I'd probably take it before you had the cup of coffee.
Okay. Somebody else has asked, I can't wrap the cuff around my own arm. Can I use a cuff that wraps around my wrist instead?
You can use the ones that wrap around the wrist. They can be a little bit less accurate than the ones that wrap around the top of your arm. But again, it's sort of about the trend. And I think generally kidney doctors are a fan of trends, aren't they? So that we sort of do the trend in the kidney function. It's the same with the trend in blood pressure. Usually we wouldn't sort of do any big actions on a blood pressure if it's a one-off. So if you're measuring it on your wrist and it's always on the wrist and it's always okay, then that's fine. If you keep measuring it on the wrist when you notice one time that on the wrist it's high, then that's something that I'd be bothered about. It's all about trends, really. But it's just slightly less accurate than it would be for on your arm.
Okay, that's great. Jane?
I actually did get an email just now from someone that was unable to join, but they're asking a question about blood pressure post-transplant.
Yeah.
So this is somebody who has had a transplant, is still on blood pressure medication, but wants to sort of know what the prognosis is. Can they expect to see a complete improvement in blood pressure, or a subtle improvement, or none at all?
So again, it depends whether there was a nephrectomy as well at the same time as the transplant or not. So if they'd done a nephrectomy before the transplant to make space, that would be a completely different situation. But that's not the common practice. So I'll talk about if you've still got both of your kidneys and you've had a transplant put in. So in Sheffield, what we do is when you're on the ward after the transplant, we pretty much stop all of your medications and then see what happens over time and add them in slowly. So again, it would be in that same stepwise that we'd add them in. So you might start in the ramipril because you've got all those extra benefits. A lot of people don't end up on the same amount that they were on before, but it kind of depends what was driving the blood pressure, really. If you've got lots of other things that haven't really changed, so we talked about things like the genetics and lifestyle choices, they haven't really changed. They're probably going to still persist, really. If it was related to the kidney disease itself, then you might not be on quite as many, but you'll be on plenty of other ones to sort of make up for it, aren't you? So overall, you'll probably still be on more medications.
There's lots of questions flying over. You've got, I'm about to start tolvaptan. What changes in BP should I look out for?
So with tolvaptan, we generally say that your blood pressure should be stable beforehand. The issue with tolvaptan is that you can become dehydrated. So you might get a dip in your blood pressure if you're not maintaining the amount of fluid intake. That's mainly how tolvaptan might affect your blood pressure. So if you're not keeping up on the fluid intake, you'll get a dip in your blood pressure and you might become symptomatic from that. So that's the lightheadedness, dizziness, that type of thing, especially if you stand up too quick.
Okay. Somebody's asked, should I aim for a lower BP if I have a brain aneurysm?
So there's no evidence that I'm aware of to say that you should be changing your target based on a brain aneurysm. It's slightly different if you've had a brain aneurysm that's burst, but for just having brain aneurysms, I'm not aware of any reason why your target should be any different to that. It's with those, it's sort of good to sort of avoid big swings. So if you avoid really high blood pressures and avoid really low blood pressures, so aiming for that same target we mentioned before is probably about right, to be honest.
Gosh, there really are lots of questions. If we don't get through all these, we will attempt to try and get back to people
right.
at the event. So let's try another one. If there's a family history of PKD, when should children start to have their blood pressure monitored? Is there an age when, if they have PKD, you would notice it in their blood pressure?
So generally with ADPKD, you might not see any changes in their blood pressure unless they've got very certain variants. Certain variants that people have can mean that children are affected, but the majority of children won't notice a change in their blood pressure. There's not I'm not aware of any set age to start. I think it kind of depends if people have got symptoms as well. If people had symptoms, so if your child had blood in the urine or anything like that, then there's probably more of an impetus to start early and check your blood pressure. If they're sort of being followed up by a paediatrician, they probably check the blood pressure when they go to that anyway. But I'm not aware of a set age that says, oh, you should start at this age. I think it's when you can, really. I think pinning down a toddler would be quite hard.
Yes.
There's a really interesting one there, Alison and Matt, and I'm slightly confused about it myself. So, do most people have high blood pressure with ADPKD? I think we already know the answer to that. But this person's blood pressure is perfectly normal, and yet they're 66.
Yeah, so sometimes that can happen. It's kind of PKD can add in, and it can make it more likely that your blood pressure is going to be high, but not everyone that's got PKD will have high blood pressure. It's all these extra things that are sort of in the background, because blood pressure's got so many different variables that it's just one of these extra variables that's going to increase the chance of you getting it. So some people might, and if you haven't, great. just means you don't have to take some tablets, I think, or make big lifestyle changes, really.
Okay, let me just find another one. Is there an alternative to tablet form BP meds? I ask because I've got a very slow stomach emptying, so medication just sits in my stomach for hours and doesn't do what it's intended to do.
So not really. So I think some can be in liquid form, which might be easier, but again, you're going to get the same problem with stomach emptying. There's a couple of blood pressure medications that are as a patch, but they tend to not work quite as well. And they're not really prescribed, to be honest. Mostly it is just tablets.
There's somebody there here asking about symptoms of high blood pressure. I mean, we do know quite often there are no symptoms, aren't there, Matt? But this person's asking about pain in the neck, pain at the base of the neck, coming across the head or front of the head. Could that be related to hypertension?
The back of the neck is unlikely, but the front of the head is usually where people feel it, to be honest. Or sometimes people feel it behind the eyes as well. So behind the eyes, top front of the head is when people feel the headaches. Visual sort of changes are another big one as well. So if people have a very high blood pressure, they might only get visual changes. So it could be that you get blurring of your vision is usually how people see it. And it's just because the blood pressure is so high, it's affecting the vessels that are in the back of the eye. So it means that the eye can't work quite as well as it should do. So you can't quite see things quite as well. So that, to be honest, those are the two main symptoms people are going to get, is going to be headache and visual changes.
Okay, so somebody's asked, if my BP is 140 over 105 at the age of 26, does this bring about a risk of strokes if it doesn't come down with medication treatment?
So it's always difficult because I don't know what medications.
Yeah,
but
it's specific.
It kind of depends on the sort of context, really. If it's a one-off that's 140 over 105, then that might not be that important. But if it's consistently above that, it means that you might be at a higher risk than someone that doesn't have that blood pressure. But the same as like high blood pressure has got loads of different things that can cause it, so does strokes. So this is just one thing that can increase the risk. There's lots of other things that increase the risk. I think the way I sort of look at it is you try and reduce all the things you can control, but ultimately there's going to be some things that you can't. So if my blood pressure was 140 over 105 at 26, I'd be having some medication, and I'd probably be titrating that medication as well, because I think you're above what I'd expect you to be or want you to be if you're my patient. So I'd be looking at the medication you're on, up titrating it, so put it to the maximum dose you could tolerate of that medication, then adding on the other ones that we talked about.
And on a sort of the next step of that, somebody said, I've got uncontrolled hypertension despite trying medications and combinations. Are there any research projects ongoing at the moment about new ways to control blood pressure?
Probably not one for me to answer.
Okay.
My research is about, someone asked about, it's about tolvaptan. So I'm looking at tolvaptan and PKD. So I probably wouldn't be aware of any, because I'm not that type of researcher. I think if your blood pressure, if you're on the full whack, that's when I would be looking for other causes of blood pressure being high. So there are some very rare causes related to certain hormones, and if you've got sort of narrowing of arteries to kidneys, that can also cause your blood pressure to be high that's not really responding to treatment. In Sheffield, we have a sort of special hypertension clinic, and that's where people would go to that. And they did look for all these sort of weird and wonderful extra causes that are beyond what you'd normally sort of get from kidney disease or PKD, that type of thing. So if it was me and mine was uncontrolled, I'd probably be speaking to the GP or to the nephrologist to see, is there anything else that might be causing the hypertension? Sometimes we don't get on top of it. And I think you sort of, there's not much that you can do about it then. You can only control what you can control, I think is the way I look at it.
Jay, have we had any more in the chat?
I've got, are there any foods that can help maintain a good blood pressure?
It's more sort of avoiding things. It's avoiding things that are like processed foods, or things that have lots of salt in, lots of fatty foods, that type of thing, rather than there being, this is a sort of superfood for hypertension. I'm not aware of that. I'm not aware of any evidence for any specific diets or anything that might help with blood pressure. It's usually a balanced diet is what we advise.
There's a question here about, this is from a 29-year-old male who was on amlodipine for a while until they read on the NHS website that it can cause infertility in men. I don't know much about that, of course. Discussed it with their GP, and they advised to switch to
doxazosine.
Thank you. Very much. Been on that for 3 months plus now, but BP average is still 150/85. Very active lifestyle, no alcohol, non-smoker. What could be causing the, I suppose, slightly elevated blood pressure?
Yeah, so I think I personally, I wasn't aware of the infertility in men, so that's not a reason that I've ever stopped it or not given it to someone. So that's new to me. Doesn't mean that it's not on the drug list. Obviously, when you get medications and it's got a long list of side effects, it's not a common one that I'm aware of. I've never stopped putting someone on it for a question of infertility. In terms of like other things, if your blood pressure is still at that level and it's been 3 months, something needs to change with the medication. Doxazosine is kind of like, I went through the steps. That's one of the sort of later ones. So I'd be thinking, why was doxazosine the first choice, is what I'd be thinking. And also what the dose you're on at the moment. Because if you've been started on doxazosine and the dose has just been stayed the same and it's not really made any difference, they need to adjust the dose. They need to increase the dose of your medication. But I personally, doxazosine wouldn't be the first one I'd have started you on. Obviously I don't know the rest of everything and the sort of rest of the context, but I'd maybe be speaking to whoever started the GP about it and say, why that one? What about ramipril? What about maybe adding a beta blocker or something like that in? And if you've got a very active lifestyle, no alcohol, no smoking, it sounds like you're doing quite a lot for things that you can adjust. So it could be things that are out of your control, like the genetics, about PKD itself, that type of thing.
Got several late entry questions here. Are there any risks of staying on bisoprolol long term? And a little bit about the any side effects on the heart.
So in terms of like long term, not really any issues. As we get older, your heart rate tends to slow down a little bit. So you might get symptoms related to your heart rate slowing down. Usually that's if you then try to exert yourself, your heart can't keep up. So you might feel faint or lightheaded, or you'd feel your pulse and your pulse rate will be low. Is what would happen.
Okay. Oh, hang on. We've got somebody coming back into the webinar. Bear with me. Talk amongst yourselves. So someone's offering a bit of advice here. It's a fair point. Reduction in red meat protein help with their EGFR.
Yeah, so that in terms of like a sort of obviously that's not related to blood pressure, but that logically makes sense because red meat. So when your body makes creatinine, which is what's used to make your EGFR, the creatinine's a breakdown product of meat and muscles. So if you don't eat as much red meat, you're not getting that amount of protein in your body. So that amount of protein is not getting broken down. So you're not going to have as much creatinine there. So it's sort of artificially changing the numbers, if that makes sense. It might not be that your kidneys are working better. It's just that you're not putting in as much of that chemical at the start. So it's sort of what's the right way to phrase it? it's sort of it's a bit like a cheat, really. You're sort of changing the sort of parameters of what's happening in the body. So rather than necessarily making your kidney better, it's making the numbers look better.
Okay. So this lady here, stage 3, she takes losartan and is suffering from sort of bad headaches. She says because of the high blood pressure, but typically when she's stressed.
Yeah. So stress is going to put your blood pressure up anyway. I think if it's persistently up and if it's high, and even when you're not stressed, so when you check your blood pressure at home, that's a completely different picture. I think if it was high all the time, and even when you're sort of outside of this stressful place, you said work, I think that would be more concerning. It's all about sort of the context, really. It depends like how high it is and sort of what the changes are, really. But it might be, I'd probably speak to the GP about it and say, these are my blood pressure readings that I get when I'm at work. These are blood pressure readings what I get when I'm at home, and sort of trying to work out whether you increase a little bit of the medication or add an extra one in. The risk is that when you're not at work and when you're not stressed, you might have a bit of a lower blood pressure than you would do otherwise. I think you look relatively young on the picture, so that's probably you tolerate it a little bit better than maybe someone that's elderly. So I'd probably be speaking to them maybe starting on another medication. But again, it's difficult without all the context. I think in a sort of trend of all the blood pressures over time and in different scenarios. You could do an ambulatory blood pressure. So that's what you ask the GP, or 24-hour blood pressure monitoring. And then they can check what your blood pressure is all the time. Yeah, 36 isn't young.
You've made a day.
I'm 34. So we'll go for that being really young and 36.
No, at first, I thought you were talking, at first when you said she looked so young, I thought you were talking about me, and I got all excited.
Yeah, you look young as well, Jane.
Oh, yeah. This, I think we've not got long, have we? But this person just wants to share some information. Went through the 3 and 4 bariatric tier 3 and 4 bariatric process, and within 10 days post surgery, BP had started heading towards normal range for the first time in over 10 years. Prior to that, they had uncontrolled blood pressure even with medication.
Yeah. So again, that's kind of saying you can control some things. That's one of the things you controlled, and good outcome, isn't it? Really, and obesity is sort of can affect your blood pressure as well. So it's sort of general sort of things you can change other than medications, that being one of them.
Yeah. Interesting.
Okay, that's great. I'd really like to thank you, Matt. I think that's we've had a few questions about tolvaptan, seeing as you.
I know, I saw that.
We're going to just for tonight's purpose, sort of we'll come back to those at a later stage, and we'll come back to those people. But I really would love to thank you for everything this evening, giving us your time. You're a great supporter of the charity, and I know that everybody who's been on the call will have benefited from that. We will be making the video available to other people who weren't able to join us this evening, and it will be available via our YouTube channel. Jane, we would ask everybody, please, if they could please take a moment to complete our feedback survey. It's really important to support us with making sure these events meet your needs, but also about showing our funders that we're meeting a need in putting these events on. So that will be in the chat, and we'll also be sending that out via email tomorrow. So hopefully you'll be able to get that. And if you could please complete, that would be absolutely great.
Yeah. A link for that is I've just dropped that into the chat. If you're able to, you could copy and paste that and drop it into a browser, and take you straight to the feedback form. I also was going to mention that regarding people's comments about tolvaptan and actually any other questions, we have a full list of recordings from previous events, and I'm going to send you that link as well. So you can head to that web page and have a look at those.
Didn't I?
You've already done one. That's what I was going to
say. That yeah. So it'll be me talking on that one as well.
So people can go straight to the recording on the website and watch that Q&A and learn more from that. So yeah. So that's great, everybody. Thank you very, very much for being with us this evening. And we will be sending out the feedback link again tomorrow via email.